Hello, my name is Dr. Dan Lozier, and in today's video, we're going to be talking about upper respiratory disorders, lower respiratory system disorders, and then also talking briefly about lung cancer. So what do you say? Let's get started. Okay, first we're going to talk about upper respiratory tract disorders. Don't forget that the upper respiratory system begins with the nares and ends at the carina. Respiratory infections, as you can see, is the most common reason why people seek healthcare. A lot of the times it is something that can be treated over the counter. People, however, don't like feeling sick. So when they have the common cold, they go to the doctor and they may be demanding antibiotics, thinking it's a bacterial infection. So all kinds of avenues for visiting the healthcare. We have Teladoc now. We've got patients going into the health clinics at your Walgreens, as an example, and then getting an appointment with your hospital care provider. Okay, when we're talking about upper respiratory disorders, we want to look at this term rhinitis that you see here. Itis is an inflammation. Rhine has to do with the nose and the nares, so it is defined as disorders characterized by inflammation and irritation of the mucous membranes of the nose. So the first we'll look at is viral rhinitis. Viral rhinitis, another term for that is acute coryza. Another term for acute coryza is the common cold. There are over 200 different types of viruses that cause the common cold. That's why it would not be unusual for you to get a cold and then subsequently get better. A few weeks later, a month later, you get another cold. You say, I should be immune to this. I just had this cold. Like, no, what you had was probably one of the 199 other strains. And as you can see, obviously, it affects a lot of people with over 1 billion people every year coming down with the common cold. Clinical manifestations, we all recognize. We have the sneezing and the runny nose. Again, there's that rhinorrhea that we talked about, watery eyes, nasal congestion. Sometimes we'll have, with that common cold, you'll have a cold, you'll have the low-grade fever, just general achiness, headache, and the symptoms of a virus last somewhere between typically 10 to 14 days. Rest, fluids are the management, non-steroidal anti-inflammatories like your aspirin and ibuprofens for your muscle aches, for your low-grade fever. Antihistamines, these are second-generation antihistamines, Claritin, Zyrtec, Allegra. Expectorants, Mucinex. Let's take a look at what that is. Sometimes when you have the cold and you have dry mucous membranes, even though you might have drainage because you're dehydrated, and your mucous membranes are kind of dry and maybe they cling to your airway, and even though you're coughing, you might hear that rattling, but you can't get it out. Well, a good medication for that would be an expectorant. Guaifenesin or Mucinex is the name, and what that does is that draws fluid into those secretions, loosens them up so that when you cough, you are able to allow those that mucus to break free from the airway, and you can cough it up. We call that a productive cough. Antivirals, an example is Tamiflu here. Antivirals do not work like antibiotics. Antibiotics actually kill the organism. What antivirals do is they slow down the replication of the organism. So in slowing down replication, what they will ultimately do is decrease the severity of the symptoms and then also the length of that illness. But honestly, the length of illness may only be reduced by 1 or 2 days. So remember, for every intervention, there's a correlating set of potential complications. All right, influenza, the flu, still causes a significant number of deaths every year. Upwards of 36,000. That's a lot of people. Two different groups of influenzas, A and B. A being the avian or bird-borne. The vaccines are going to change every year, and I know a lot of us are still required to get the flu vaccine. The vaccines change every year. Why? Because the virus changes every year. So we're trying desperately, we as the healthcare community, to keep up with the different types of influenza, and how that organisms changes. Sometimes the vaccine doesn't necessarily have the level of efficacy to prevent patients from getting influenza. To some degree in the past years, there could be only 20 to 30% effectiveness of some of the vaccines. So, stay tuned every year for how efficient and effective those vaccines are. Clinical manifestations of the flu, yes, they do differ from common cold. Cough, a lot of times we have not a low-grade fever, but you could have a pretty significant fever, headache, myalgia, uncomplicated cases. So typically are going to resolve within 7 days. The problem is, and why we're looking at that 36,000 individuals that die, is that when you have an upper respiratory viral infection like the flu, that tends to actually compromise your immune system. It distracts your immune system. It stresses your immune system. And what that does is that allows, particularly in the vulnerable population, that allows for an opportunistic lower respiratory infection to settle in, and that one's oftentimes bacterial. So in a common uncomplicated case of influenza, if you are assessing a patient that's admitted to your unit for influenza, you are not expecting to hear crackles and to observe dyspnea on our patients. That is a complication. That is what's going to lead to that 36,000 individuals that die. So when you are assessing your patient for influenza and you hear lower respiratory dyspnea and crackles, that requires immediate attention from the medical staff. We do have vaccinations, as I mentioned before. And antibiotics, why don't we just give them antibiotics? Well, it's not a bacterial organism, it's a virus. And so viruses do not respond to antibiotics. Good technique here, by the way. Looking good. Okay, wow, H1N1. H1N1 burst on the scene back in April of 2009. In the United States, and whoa, within 2 months, look at that, between April and June, now we have a worldwide pandemic. I don't know how they figured this out. What we did know is that people were dying from H1N1. They sent out their gurus, and they were able to find out, look at this, that H1N1 came from two genes from flu viruses that normally circulate in pigs in Europe and Asia, plus bird genes. And a human gene. So pigs, birds, and genes. So, who be messing with the pigs and the birds would be a good question to ask. I don't know. I don't know. So it was spread from human to human, and the signs and symptoms. That's what kind of confused us, because the signs and symptoms, if you took the signs and symptoms of the common cold and mixed them together with the signs and the symptoms that come with the flu, that's what we were seeing. So you might have respiratory issues, but the patient didn't have fever. And so that was something that was new to us. And here's what's probably most alarming. Normally, when we think of the flu, when we think of patients dying from the flu, we're going to think of the elderly patients. But the elderly weren't the ones that were primarily at risk. That was individuals ages 25 and younger. So that certainly was enough to startle us. We anticipated and kind of expected that the elderly population might be at risk. But really, those who developed complications from H1N1 more often than not. In fact, in 70%, they had a pre-existing condition, something that would compromise their immune system. Antivirals, again, antibiotics won't work because it is viral. Antivirals such as Tamiflu, again, does not kill the organism, but inhibits replication of the organism, thereby decreasing the length of the illness and the severity of the symptoms. All right, so now we have our vaccinations, but the vaccination for H1N1 is now actually included within when you get your flu shot, your flu vaccination, the H1N1 is included in that. Oh boy, coronavirus. At the time of the production of this video, we are right in the middle of the pandemic of COVID. I'm not even sure that we're in the middle. Maybe worldwide we're in the middle, but in the United States, we're just getting to the point where it's very heightened, and patients are dying. What we do know about COVID-19, it is a novel coronavirus. That we have not seen before. As I mentioned, patients are dying from this. Tends to have your upper respiratory symptoms, which is your cough and fever. Maybe some indication that some of the early signs might be GI, but that's not been confirmed yet. There's no vaccination confirmed for it. And there's no medications that have been released on the market and FDA approved to treat it. So stay tuned, and we're learning as we go every day on the coronavirus right now. The primary way of inhibiting the growth and spread of the coronavirus is through social isolation, which we're seeing to varying degrees, from keeping 6 feet apart to complete closure of schools, businesses, restaurants, bars, and it is having a major impact, including even the state of California being on a pretty much of a lockdown, what they call the secure in place. Now we're moving into a lower respiratory tract infections. Again, remember the lower respiratory tract begins below the carina, so we're talking about the right and left main stem bronchi, the bronchioles, and the alveoli. Atelectasis, I don't know if you remember from the initial video, we talked about atelectasis. Atelectasis is collapse of the alveoli. The alveoli are the great black clusters that are at the most distal section of the tracheobronchial tree. That's the place where diffusion happens. The primary gas exchange happens in the alveoli. If you remember, the alveoli manufacture and secrete a substance called surfactant. And surfactant, when it is secreted, actually will decrease the surface tension on the alveoli. And what that does is that on exhalation, it's going to prevent the alveoli from collapsing on itself, because when the alveoli collapses on itself, it's very difficult to open that back up. And then obviously if the alveoli have collapsed, there's no gas exchange that's happening. So life-threatening situation if not reversed. Some of the causes of atelectasis. Hypoventilation. When might a patient be hypoventilating? Let's say that a patient has comes back from surgery, has abdominal surgery or chest surgery, thoracic surgery, and it just hurts when they take a deep breath, so they may hypoventilate in that situation. Your immobility is a big one for causing atelectasis. Postoperatively, the patient is just heavily sedated. There's been a suppression, and the normal brain center that controls respirations and pain medications possibly, or again, that pain that I mentioned, that patient doesn't want to take a deep breath because every time they do, it feels like a mule's kicking them. Patient laying supine, get that patient, sit them up. So what are the symptoms? Well, it varies with severity, but obviously atelectasis, when you have a decrease in the number of alveoli that are able to participate in gas exchange, you're going to have a buildup in CO2, and you're going to have a decrease in circulating oxygen, hypoxemia, and decrease in oxygen that actually is getting to the cells and tissues of the body, which is hypoxia. So how does the body respond when there's a decrease in oxygen? Dyspnea. You can have cough, sputum production, cyanosis from decreased circulating oxygen, tachycardia, tachypnea, and hypoxia. None of those certainly would be surprises when we have a decrease in oxygenation. How do we prevent it? Look at this: coughing and deep breathing, cough and deep breathing, and incentive spirometry, the old incentive spirometer. Incentive spirometry and cough and deep breathe prevents pneumonia, but also prevents atelectasis, or helps, I shouldn't say prevent, but mitigates the potential of developing atelectasis. Pleural effusion. Remember we mentioned that there is a lining of the lung right here, lining of the lung, and then there's the lining of the chest wall. The lining of the chest wall is the parietal pleura. The lining of the lung is the visceral pleura. In between, that is the pleural space. Now, normally, if you look over here, that's the pleural space. Normally, the two membranes are adhering to each other. There's a negative pressure in there. But with the onset of accumulation of abnormal fluid in the pleural space, as is denoted down here, that is called a pleural effusion. Pleural effusion. Do not confuse that with pulmonary edema. Pulmonary edema is an abnormal accumulation of fluid in the alveoli and or the lung tissues. Pleural effusion is an abnormal accumulation of fluid in the pleural space. Remember, it could be just normally the body is going to manufacture and secrete a small amount of pleural fluid to help adhere the two membranes together in that negative pressure. It could be blood. It could be purulent exudate. Remember, we said that there was pus in the pleural space, and the term for that was empyema. Empyema. Right, not a primary disease, but pleural effusion. It is a complication of heart failure, complication of pneumonia, pulmonary emboli, pulmonary infections. In fact, when we do get to pneumonia, we're going to see that, gosh, about 30% of patients that have pneumonia are going to develop a pleural effusion. Also with pleural effusion, remember the way that we get that fluid out of there is through the thoracentesis. Pulmonary edema, again, not to be confused, abnormal accumulation of fluid in the lung tissue and or the alveola. Hallmark sign for pulmonary edema is pink frothy sputum. Pink frothy sputum. Good thing to know. The primary cause of pulmonary edema is heart failure. So because it is heart failure, this term here, cardiogenic, it's cardiogenic pulmonary edema. Genesis, in the beginning, like in the Bible, cardio, Genesis, where it started from a cardiac cause, cardiogenic. We're going to learn probably in the next video about a non-cardiogenic. This is a patient that has a perfectly, in most situations, perfectly healthy heart, but something else is causing an abnormal accumulation of fluid in the alveoli. And that's when we'll talk about ARDS, which kicks off SIRS, coming soon to a slide near you. This is a normal chest x-ray. We want to see this nice dark diffusion. that nice dark diffusion of air. Remember in GI, we didn't want to see free air in the abdomen. That was an example of peritonitis, but we do want to see the air in the chest. You can see not only the anterior, but you can also see the posterior ribs as well. Nice hemidiaphragms on either side. You have a nice heart silhouette here, normal size heart silhouette. Look at this, is a patient with pulmonary edema, and you can see how the patient would fairly quickly develop respiratory compromise. Pulmonary edema is a life-threatening complication, and look, I said that the primary etiology or cause of pulmonary edema is heart failure. Look at this. Look at the difference in the diaphragms here, and look at the size of the heart. Look at the size of this heart in the patient. So, although I don't know, my guess is that this is a cardiogenic cause for this patient's pulmonary edema. Pneumonia, P pneumonia. Let's look at that. Almost always, let's just say primarily caused by a microbial organism. So definition, another definition, I like my definitions. Pneumonia is an acute inflammation of the lung parenchyma. Oh my gosh, I thought we'd never see that term again. That was all the way back in video number 1, where we saw an inflammation of the lung parenchyma. Remember, the lung parenchyma is the term used for those two anatomical structures in the tracheobronchial tree that participate in gas exchange. And so you have an inflammatory response, which is affecting those two areas, anatomical structures. So you're going to have an inhibition and the ability for oxygen and CO2 to diffuse. So you're going to be seeing some respiratory symptoms of respiratory compromise. Wow, leading cause of death until the development of sulfa drugs and penicillin in 36. Pneumonia and influenza together are the 8th leading cause of death in the United States, and the most common cause of death from infectious diseases, approximately 56,000 every year. That's a lot of people. And remember, if you happen to be an individual who is going to be having a test on this material, that I am not going to be using statistics such as the 8th leading cause or the number 56,000 a year. Same way up here. Not going to be requiring you to apply that in any future test. I do want you, however, to pay attention to the different classifications of pneumonia. Community-acquired pneumonia, CAP, community-acquired pneumonia, CAP. The definition for community-acquired pneumonia is either the patient presents to the hospital with symptoms of pneumonia, or the symptoms develop within 48 hours of admission. So where did that patient acquire the pneumonia? Out in the community. They didn't acquire it in the hospital because they either came with the symptoms of pneumonia or the symptoms developed within 48 hours of their admission or presentation to the hospital. Hospital-acquired pneumonia, HAP, hospital-acquired pneumonia. On the other hand, it is pneumonia in which the symptoms develop 48 hours or longer after hospital admission. So community-acquired was that the symptoms developed within 48 hours, or they came to the hospital with the symptoms. Hospital-acquired, which means that, yes, they got the infection in the hospital, is when the symptoms develop greater than 48 hours after admission. Tends to be a stronger, more virulent type of microorganism as well. Now, the healthcare-associated pneumonia, which is the last one, by the way, make sure you be able to articulate community-acquired from hospital-acquired from healthcare-associated. So you can't really see it because my mug is probably blocking it over there, but healthcare-associated pneumonia is HCAP, healthcare-associated pneumonia. in these situations for these patients, these are the kind of patients who have multiple comorbidities. And on any given day of any given week, they might be seeing their endocrinologist, their cardiologist, their pulmonologist, their nephrologist, and so they have multiple comorbidities, and they have a propensity to have a higher incidence of infections and other complications. And these are the patients that are spending a lot of time on antibiotics. And so those patients, when they come into the hospital and they develop pneumonia, it's not fair to pin that on the hospital. So healthcare associated pneumonia, those patients that have multiple comorbidities tend to be on a lot of antibiotics. But you also can't quite see the end to here. What I want you to know is that the causative pathogen is oftentimes multi-drug resistant, MER. Multi-drug resistant, again, because these patients spend a lot of time with exposure to a variety of different antibiotics. They tend to develop a resistance to antibiotics. Those patients can get very sick very quickly. Predisposing risk factors, smoking. I will get on my soapbox shortly about smoking. There is nothing good about smoking. In my humble opinion, it should be eradicated from at least America here. And I'll tell you why up front. That my father died of lung cancer primarily because he smoked. He smoked cigarettes, and even though he hadn't smoked for over 30 years, the damage was done. My grandchildren never got a chance to see and to enjoy their grandfather, who was a wonderful man. My mother-in-law died from lung cancer when my wife was a senior in high school. Why? Because she was a cigarette smoker. My sister, one of two sisters, my sister died from COPD at the age of 61. Why so young? Because of cigarette smoking. That's why I'm very adamant, and as well as anyone that has a healthcare background or a healthcare bent should be pushing towards eradicating smoking from society. Aging is a risk factor. So funny, whenever I'm doing the respiratory lecture, I always start coughing. That's kind of a psychosomatic issue with me. No, I don't have COVID at this time. So it happens all the time. Altered level of consciousness. So that patient could have aspirin pneumonia because they were severely inebriated. Intoxicated, central nervous system is depressed, suppressed, and they vomit, and then that aspirate goes down the trachea. Prolonged immobility, which is why we want to get our patients up and moving, because it is a significant risk for pneumonia. Malnutrition, that malnutrition is going to compromise a patient's immune system and make them more susceptible to infections such as pneumonia. Oftentimes patients will start with an upper respiratory infection. We talked about that, such as the common cold, influenza. And the common cold, influenza, that viral infection is going to distract the immune system. And the immune system at that point, a lower bacterial infection is going to come into the lower respiratory system and could cause a fulminant pneumonia. Tracheal intubation because it's a sterile airway. And these other predisposing risk factors, COPD, chronic obstructive pulmonary disease. These patients are going to spend the rest of their life from diagnosis in and out of the hospital with pneumonia because of the compromise to their lungs, the inability to clear secretions, and it's a very sad situation. Heart failure predisposes patients to pneumonia, diabetes, and AIDS. And so this is, we kind of mentioned that typically it's a bacterial organism. They could acquire it, however, through aspiration. That's the patient that would be inebriated and suppressed gag reflex. inhalation, and hematogenous spread. Hematogenous spread means that it might have started, that bacterial organism might have started somewhere else in the body, got into the bloodstream, hema, and then spread to the lungs as a secondary site. Clinical signs and symptoms. These are kind of all very important for you to know. Primarily, I would say that these are the ones I want you to be able to recognize. Fever, shaking and chills, and sometimes the shaking and chills start before the patient has the fever. The greater the number of alveoli that are now inflamed because of the inflammation of the lung parenchyma, the decrease in the oxygenation, the more that the brain is going to trigger as a response, and an increase in the respiratory rate to try to compensate for that hypoxia and hypoxemia. Cough. But here's a good one: sputum. I like my sputum. Rust-colored sputum. This is the only one that is going to have rust-colored sputum. There's going to be a couple that might have blood-tinged sputum, but pneumonia is rust-colored sputum. Remember that pulmonary edema is going to be pink, frothy sputum. Why would it cause confusion in the geriatric population? Well, sometimes infections just cause confusion in our geriatric population. But the other reason that you might have confusion is that hypoxemia and hypoxia may be affecting the brain, which in turn you're going to note some altered mental status in your patients. Complications, woo, here we go again. Pleural effusion, an abnormal accumulation of fluid in the pleural space. And approximately 30% of bacterial-caused pneumonias, not viral. You're going to see your patient have that probability of developing pleural effusion. Bacteremia, where, boy, now the bacterial organism has gotten into the blood and is traveling to multiple organs of the body. The multiple organs of the body begin to shut down, and then you see your septic shock. Atelectasis, which is the collapse of the alveoli. That inflammatory response could inhibit the secretion of surfactant, and which increases surface tension, and then upon exhalation the alveoli are going to close, and then they're going to collapse. And certainly respiratory failure if the pneumonia continues to exacerbate and treatment is not available. Chest x-rays are great. Chest x-rays can determine and sometimes whether or not it's a viral versus a bacterial infection, where viral infection might be more diffuse throughout the lung fields, but a bacterial infection might be lobular, or in other words, it might be socked into one lobe of the lungs. Blood cultures, particularly as we're looking at hematogenous spread or we're looking at bacteremia, not so much maybe for bronchoscopy, but in case we had to visualize the airway, bronchoscopy for whatever reason could be a good diagnostic tool. Alrighty, look at this. So we're looking at pneumonia here, nice clear lung fields, and then we have what appears to be here a more lobular indication for pneumonia versus diffuse throughout the lung fields. Care, collaborative care, antibiotic therapy if it's a bacterial infection, hydration, and nutrition. Patients that feel sick and with pneumonia, I've had it twice, and you are sick as a dog both times that I had it. I didn't feel like eating, and I certainly, if I can't breathe, I don't feel like drinking. Not only that, I'm at a risk for dehydration. As you recall, with your inhalation and exhalation, when your normal respiratory rate is going to be 12 to 20 times a minute. Let's say that this individual is an elderly individual and their normal respiratory rate is 14 breaths per minute, and now they're cranking away at 22. Um, they are also, you're looking at insensible water loss from that increase in respiratory rate. So I have a decrease in intake of fluids and increase in output of fluids from the insensible water loss, and quickly that patient can develop into dehydration. The pneumococcal vaccination is a vaccination specifically for pneumococcal pneumonia. I had two really bad cases where I was really sick with pneumonia, and went to a pulmonologist, and they weren't sure what's going on. Finally got it to clear, and I was then ordered to receive the pneumococcal vac. Sometimes you'll see it as pneumovac. Boom, haven't had it since, and it's been several decades since I had my last bout with pneumonia, and I specifically relate that to the fact that I had the pneumococcal vaccination. No problems with pneumonia since. Nursing diagnoses, ineffective airway clearance. Remember that ineffective airway clearance is the inability of the patient to productively cough. So that might be that situation where the patient is dehydrated and they have thick viscous secretions. They're coughing, they can hear and they're rattling and feel the rattling in their chest of the secretions, but they can't get them up. That might be the situation in which we might give guaifenesin, Mucinex for that patient, pull fluids into the secretions, loosen them up so that they can cough and clear their airway. That's not to be confused in the later slide when we see impaired gas exchange. Impaired gas exchange is at the alveolar level, and it's not to be confused with ineffective airway clearance, which is the inability of the patient to cough. There I go again, talking about coughing, and suddenly that triggers a psychosomatic response here. Activity intolerance. I tell you, the patients that have pneumonia, they are going to be wiped out. So cluster your care. Risk for fluid volume deficit. You really don't feel like drinking when you can't breathe, or eating. Imbalanced nutrition. TB, tuberculosis, TB. There was a point in my nursing career, and I've been a nurse now for over 30 years, when we didn't talk about tuberculosis. You really didn't worry about tuberculosis. You didn't see tuberculosis, and I worked in a children's hospital, and in intensive care transport as a flight nurse, and we just didn't see patients with tuberculosis. Now we're seeing. Look at this. Tuberculosis is the world's leading cause of death from infectious disease. What about HIV? No, world's leading cause of death. Approximately 1.5 million patients every year. So important. I look at that. I've got one large parenthesis and one small one. Oops. Okay, here's a startling statistic. It is estimated that half of the world is infected with TB. So if we're hovering around 7 billion people, that's approximately 3.5 billion people are infected with TB. That doesn't mean that they have the active TB disease, but they're infected with a microbacteria organism, which is Microbacteria tuberculosis, M. tuberculosis. Half of the world's population. The United States reports about 14,000 new cases every year. So far from eradicating it, we are seeing TB. Certain populations and locations where we're seeing the cases. We'll see in an upcoming slide those patients who are more at risk. Good thing that you can see on this slide here is that over a period of time, we were seeing a decrease in death rates, and I think that was attributed to the fact that we kind of found out that drug cocktail that would work, that 3-drug cocktail. But now we're starting to see multi-drug resistant and extremely multi-drug resistant organisms or strains of the tuberculosis pathogen. TB, yes, it is, contagious. It's an infectious disease, but it's not where the person, if somebody walks in the room and they're talking to you for 10 minutes and then they walk out of the room and you find out that, oh, that patient had active TB, your chances are remote of getting contracting TB or being infected with TB because of that interaction. The patients that have acquired TB, or those individuals at risk, are those who come in contact with someone that has active TB, and it's close, prolonged, frequent contact, and we're talking intimate levels like 6 inches or less. Close, prolonged, intimate relationship or contact with an individual that has active TB, not the infection. That's actually active TB where it is replicating. Lower socioeconomic groups tend to have a higher risk for developing TB, any of a number of reasons, from ineffective healthcare to lack of vaccinations, etc. Homeless and the elderly people tend to have compromised immune system. Compromised immune system is a high risk factor for TB infection transitioning into active TB disease. Foreign-born persons, Philippines, India, China, and Vietnam are the four countries the World Health Organization is currently saying have the highest incidence rates of tuberculosis. Institutionalized patients, which would make sense for that close, frequent, prolonged contact. Look at this, HIV. So any form of immunosuppression puts a patient at higher risk for the development of TB. But HIV, AIDS, 1 in every 3 individuals that are currently living with HIV/AIDS have tuberculosis. That's a pretty startling statistic. So what is the etiology and pathophysiology of tuberculosis? The M. tuberculosis is an acid-fast bacillus, AFB, acid-fast bacillus. That's the only really pathogen that I'm going to want you to know about. It's spread from person to person via airborne droplets, which can remain airborne for a prolonged period of time. So again, the transmission is close, frequent, prolonged exposure. And that's for, the aerosolization happens when the patient has it, the active TB down in the lung area, and coughing and sneezing and singing are all potential ways in which it can become airborne: coughing, sneezing, singing, etc. A very small droplet. I said it can remain airborne for quite a period of time, minutes to hours. So what happens? So when the droplet over prolonged contact eventually, because of the prolonged nature and the more up close nature of the exposure, some of those airborne droplets of the microbacteria tuberculosis are going to find their way into the lungs. So when they find their way into the lungs are just the perfect medium for whatever reason for the tuberculosis pathogen. The good news is that in 80% of the cases, the immune system is not going to be compromised in patients, and the immune system is immediately going to respond to the presence of the pathogen, the acid-fast bacillus, and is going to wall it off. That's the good news. It's going to wall it off, and it is not going to spread. Because it's not spreading, it's not the active disease. It is walled off. It's viable. It can become active disease, but it's walled off by the immune system. And as long as the immune system doesn't face a severe compromise, it's going to be that way for the rest of that patient's life. This you can't see it too well here, but this right here is what you might see with a patient that has active TB. So active TB is eventually going to replicate within the alveoli, and it's going to destroy large numbers of alveoli. And so when the large numbers of alveoli are destroyed, what you have in effect is one giant alveoli in which gas exchange does not happen. They call it air-filled cavities, or bulla. And that's when a patient has a positive potential PPD, or you have a possible PPD or Manteau test that's positive, and they say we need to get a chest X-ray. That's what they're looking for right here, and that's an indication of active tuberculosis disease. If, as is in the case, 80 to 90% of the time, I think in my other slide I said 80%. That may, be maybe a little conservative, and perhaps it's closer to in 90% of the individuals that are exposed to the infection. It gets walled off by their immune system, and it doesn't replicate. So in that remaining 10% of the cases, it is going to actually become the active tuberculosis disease. When the patient has had exposure to the infection, and they have the microorganism, they have the pathogen in their lungs, but it is walled off and it is dormant because of the healthy immune system. That's called latent TB infection. So that's when we talked about the 1/2 of the world's population are infected. That's the latent TB infection. It's there, it's dormant, and predominantly 90% of the times, but it does have the potential with compromise or insult to the immune system to become the active disease, which replicates. The active disease is when that patient presents with clinical manifestations. This is just an excellent slide down here indicating what aerosolization really looks like with this patient sneezing. What a great. So patient sneezing, close, frequent, prolonged contact. Those are the individuals at high risk for getting not only exposure, but actually getting infected with the tuberculosis infection. All right, clinical signs and symptoms or manifestations of active tuberculosis: fatigue, cough, sputum, blood-tinged sputum, purulent. You can see that with a number of respiratory infections. So this doesn't necessarily indicate that, even decrease in appetite doesn't necessarily indicate that it's anything unusual other than a potential lower respiratory infection, which could even be viral. Not necessarily bacterial, but these are the three kind of unusual clinical manifestations that you might see. Unexplained weight loss on a patient, low-grade fevers that tend to spike in the afternoon, and the patient wakes up just drenched with sweat. So these are the three I might want you to be able to recognize as potential indications that we're looking at more than just a lower respiratory infection. We actually may be looking at a patient that has tuberculosis. Unexplained weight loss, low-grade fevers, and night sweats. Biliary TB is a complication of tuberculosis. Tuberculosis will start in the lungs, and then sometimes you might see on a patient's electronic health record, they have pulmonary TB. You're like, of course it's in the lungs. No, pulmonary TB just means that it is isolated in the lungs. Once it begins to spread and replicate, it can go to any organ of the body. When it has extended beyond just the lungs, to another organ of the body, brain, kidneys, bones, lymph nodes, it is now called miliary TB. Miliary TB is the term given to the tuberculosis when it is spread from the lungs to other organs. Pleural effusion, there we go again, which is an abnormal accumulation of fluid in the pleural space, not to be confused with pneumonia, which is an inflammation of the lung parenchyma. Wow, I'm stressing those definitions a lot. I bet you might have to be able to remember those if ever you take a nursing test in your future. Diagnostic studies. This was always the gold standard, the go-to, the PPD, purified protein derivative, the Manteau test. Where we would get intradermal, we'd look for the bleb and then come back and have it looked at 48 to 72 hours later. And what you're looking for is a positive result, excuse me, which is erythema and enduration. Erythema is redness and enduration is hardness. So a reddened area that is also hard. A positive result is would be that that area would be 10 millimeters or greater. 10 millimeters and greater where you have redness and you have hardness. I believe for HIV patients it's 5 millimeters or larger. Here we go, a chest x-ray. If you have a positive PPD, we're looking for that air-filled cavities or bulla. Typically it's in the upper lobes, which would make sense. That's the first place where frequent prolonged exposure or contact, the M. tuberculosis is going to land in the upper lobes. So that's usually on x-ray, just like the previous x-ray, where we're going to see it is in the upper lobes. The problem is, remember we talked about the transient nature of the population, particularly if it's a homeless population, lower socioeconomic population, they're transient. They're going to go where they have housing. They're going to go where they have jobs. Sometimes, the chances of some of the individuals that might show up at a clinic being there 72 hours later or 3 days later, may be slim to none. They could be in a whole nother state by that time. So something needed to come up which would allow for a faster, particular in more third world countries, and that is the expert assay. Look at that, the expert assay, which was really pushed by the World Health Organization, can help to diagnose multi-drug resistant tuberculosis. The problem is it's very, very expensive, and somehow they shoot a laser through sputum and they're able to figure it out. People a whole lot smarter than I am, and thank God that we have those brainiacs. QuantiFERON Gold. Some of the hospitals, even our area in the Cincinnati area, are moving towards the QuantiFERON Gold as what they're testing their employees with to see if they've had exposure. Again, it's a lot quicker. It's 24 hours. The other thing that's nice with the blood tests of the QuantiFERON Gold is that if a patient has had previous exposure to tuberculosis, that say that they're infected, but it's not active disease, they're more likely than not going to have a positive Manteau test if they've had exposure. Likewise, if some of the countries, they will actually vaccinize their patient population, and those patients that have been vaccinated for tuberculosis will always have a positive PPD. That's not going to show up with your QuantiFERON Gold. It won't show up as a false positive from vaccination. All right, here we go. What confirms the diagnosis of TB? The only confirmed diagnostic procedure to indicate, yes, for sure, the patient has tuberculosis is a sputum culture. A sputum culture that's positive for the acid-fast bacillus, AFB, of Microbacteria tuberculosis. So positive sputum culture is the only diagnostic procedure to positively confirm that a patient has active tuberculosis. Different kinds of drug therapy, and it's interesting. There was actually one question on NCLEX for this. There wasn't NCLEX, I'm sorry, it was our ATI MedSurg module on drug therapy. So if a patient has the latent TB infection, remember they've been exposed to the TB, the immune system has walled it off. Even though it's dormant, they're at a high risk for immunocompromise. So whatever that reason, lower socioeconomic, HIV, patients that have multiple comorbidities, they may be at a high risk population for it moving from latent TB infection to active disease. So in those individuals, they might be required to take medication. In that situation, INH or isoniazid. But look at this, they have to take the medication, which, yes, will prevent them from getting tuberculosis for 6 to 9 months. 6 to 9 months. That's a long period of time. We have a difficult time getting patients to take their medications for 10 to 14 days for an antibiotic. 6 to 9 months. Again, look at the population that we talked about: homeless, lower socioeconomic, a transient population. You know, they might not have the money, they might not have the ability to, access wherever they're going to pick up the drugs. They might be here today, gone tomorrow. And so that's the problem with they start taking the medication and then they stop. And that's when we start developing the multi-drug resistant and extensively multi-drug resistant forms of the pathogen. Active disease used to be that we got pretty excited if we give them this 4-drug cocktail of INH, rifampin, PZA, and ethambutol. We had a pretty good success rate. Unfortunately, we're finding that we're having some multi-drug resistant this is not effective with this 4-drug cocktail. But look at this, even this, if it's not a multi-drug resistant, we got 4 medications that the patient is taking for 6 months. Again, remember that population: homeless, lower socioeconomic, transient population. We're seeing an increase in multi-drug resistant forms of tuberculosis. Fluoroquinolones and aminoglycosides, don't really have to know that for right now, but those are being employed against the multi-drug resistant forms of tuberculosis. Now we got this scary pathogen out there that we call the extensively drug resistant form of tuberculosis. And guess what? We don't know how to cure that. So we've got a form of TB out there that we don't know how to cure with a patient. This extensively drug resistance to INH, rifampin up here, fluoroquinolones, injectables, aminoglycosides. So there are some experimental treatments that are being done, but we don't have any longitudinal studies. We don't know if this drug is absolutely going to work. We don't know what the long-term impact might be of taking this medication. We don't know the appropriate dose of the medication yet. So we're in virgin territory here. Vaccines, I mentioned earlier that there are some countries, not in the United States, that will actually vaccinate their infants against tuberculosis. That vaccine is BCG. It's a French name. And what I had mentioned earlier as far as diagnostic tools, if the patient has had the vaccination as an infant, they will almost always have a positive PPD. And that's where that the gold test, quantiferin gold, actually does not pick up a false positive from a patient that has had the vaccination. Alrighty, ineffective breathing, imbalanced nutrition, non-compliance. Make sure when you use this term non-compliance that you're not being judgmental. The greatest, probably the best way to use that if you say non-compliance to the treatment regimen, because they don't have a knowledge of the disease process. And so we want to, encourage compliance of the regimen. Remember, we're talking 6 to 9 months for those medications and prevent the spread of disease. What's the easiest way to prevent the spread of disease for patient education? Is the patient covers their mouth when they cough or sneeze. The patient avoids large crowds. Being in large crowds, a patient avoids being around younger children or older individuals because of the immune system is compromised in those individuals, either from the lack of maturity in the young child of the immune system, or it's beginning to decrease in its efficacy in the elderly population. We talked about the vaccine. There's just so many things wrong with this picture. Number one, what in the world are they doing giving an intramuscular? Or I guess that looks like it's in the patient's deltoid. I mean, this little guy might be ripped, but he certainly doesn't have appropriate sized deltoids. No gloves on there, all kinds of things. That's not what we want to be looking at. All right, I don't know why I keep that picture up, but I think it's just, we're talking about vaccinations. Maybe it's the best picture I was able to find for that. But we do not vaccinate our children in the United States. We found that there is still a statistically relevant number of patients that have been vaccinated in other countries and still can develop the disease. I think it's like in the later teens, early adulthood. All right, the final topic in our video today is going to be on lung cancer. Cancer, as you may recall, is the #2 killer of Americans. So #1 killer of Americans is cardiovascular disease. One of the top 3 risk factors for cardiovascular disease is cigarette smoking. #2 killer of Americans is cancer. The #1 cancer killer in both men and women is lung cancer. #1 predisposing risk factor for lung cancer, you got it, smoking. So let's talk a little bit about lung cancer. So you can see, as I talked about here, that it's the #1 cause of cancer deaths in both men as well as in women. So you're going to have a whole module which talks about what cancer is and an abnormal proliferation and differentiation of cells. I'm just going to briefly highlight a couple things I want you to know regarding lung cancer. Number one, it's the most serious type of cancer. I said it's the #1 killer of all cancer types. I think this number is conservative, saying that 85% caused by smoking. I think it's even higher than that. And here's the concern, is that it may take 10 years or more before it is detected. Not unusual for you to hear a story about Uncle Charlie or the next door neighbor Fred or whoever it might be that was diagnosed with lung cancer, and 6 months later they were dead. The problem is, and why we hear that story frequently, is that it often takes 10 years before it's able to be detected by diagnostic radiology. So that means that it's been growing and multiplying for 10 years. So unfortunately, oftentimes when lung cancer is caught, it's too late and the disease has progressed considerably. Not a lot on this slide that we did mention. That's primarily noted late in the disease, and the one early manifestation that might lead someone to seek medical attention, that might allow them to get a chest X-ray, would be a complaint of a persistent cough. But as the other slide said, that it's oftentimes very silent and deadly. And this is the final slide. I'm not going to go into detail on the treatment for lung cancer. You see that surgery, chemotherapy, and radiation are indicated on the slide. And the reason I'm not going to go into it now is that you're going to have a whole module, as I said before, on cancer and oncology, and it's going to be covered at that time. This actually wraps up our video for today. I want to thank you for watching this video. Stay healthy and be strong.